Okay, good evening, everyone. I'm Susan L., Vice President and Executive Director of the Foundation for Barnes-Jewish Hospital. Welcome to everyone who is here in person and to those who are joining us online streaming the program and to those in the future who will be looking at the recording. We thank you for coming out on this chilly, chilly evening in St. Louis. And I promise you, the program this evening is going to warm your hearts. So, warmth is on the way. Our Leading Edge Medicine series is an exclusive opportunity to hear firsthand about the incredible innovations and discoveries happening right here in St. Louis. Tonight, you'll gain valuable insight into the future of healthcare from Debra Parker Oliver, the Ira Codner, MD, Endowed Chair in Supportive Care Research in the Division of Palliative Medicine at Washington University. Dr. Parker Oliver, right here, she's going to be speaking in a moment, is the very first to hold this chair. The Division of Palliative Medicine was established in 2018 through a remarkable collaborative effort between the Department of Medicine at Washington University, BJC Healthcare, Barnes-Jewish Hospital, and the Foundation for Barnes-Jewish Hospital. We are tremendously grateful to John and Ann McDonnell for establishing this chair in supportive care research to honor Dr. Ira Codner. Let's hear it for Dr. Ira Codner. We love that. He is a pioneer in palliative medicine and supportive care at Barnes-Jewish Hospital and Washington University School of Medicine. The McDonnells also generously committed a transformational gift to endow the Institute for Supportive Care at BJC Healthcare through the Foundation for Barnes-Jewish Hospital. These gifts have swung the door wide open for Dr. Parker Oliver to pursue her important work. Through her chair position, she has made significant strides in research and discovery to transform a field that is a new frontier in so many aspects. Dr. Parker Oliver's research work will have far-reaching effects for generations. We're grateful for our visionary donors who make this vital progress like this possible to advance our mission to enrich lives, save lives, improve community health, and transform healthcare. Dr. Angeline Peters-Lewis, Chief Operating Officer at Barnes-Jewish Hospital, will share more about Dr. Parker Oliver in just a moment. First, I would like to recognize the Foundation's Board of Directors who are wearing their silver name tags here this evening. Thank you for all you do, the board, on behalf of the Foundation and our hospitals and the community. Our Foundation team members are also wearing the silver name tags, so please be sure to say hello to them. Also hello to and greetings, and we are so glad that there's so much BJC leadership and Washington University leadership here this evening. And for those of you who are streaming and going to be watching this in the future, you're missing out on being here at a really great event in person. So please, I'd like to welcome Dr. Angeline Peters-Lewis to come and introduce our speaker. Angeline.
Good evening. Thank you, Susan. I'm honored to be here to introduce Dr. Parker Oliver. Her vast expertise and experiences have given her special insight to be able to talk about life's journey and the evolving role of healthcare in that journey. Can you all hear me? Yes. A little closer? Better? How's that? Perfect. Dr. Parker Oliver brings a unique perspective on palliative care professionally as well as through a very personal, emotional experience, the intersection between the personal and the professional. Sadly, in September of 2011, her husband David was diagnosed with terminal cancer. Together, the couple experienced the full continuum of cancer care, including treatment, palliative care, and hospice care. To educate and comfort others, they decided to courageously share their journey through a video blog over nearly 4 years. Their goal was to take the strangeness out of dying. David and Debbie appeared on CBS This Morning, as well as many other media outlets. Today, their videos have been seen by thousands around the world. Sadly, David passed away in 2015, but left a life-changing legacy through these videos, and through his wife, who continues their mission. After her husband passed away, Dr. Parker Oliver published an award-winning memoir of her caregiver story called Legacies from the Living Room, A Love, Grief, Education. Her personal journey has aligned with her education and professional experience. Dr. Parker Oliver has a master's degree in social work and a PhD in rural sociology from the University of Missouri. Prior to earning her PhD, she founded Hands of Hope Hospice in St. Joseph, Missouri, and served as a hospice director in 2 additional hospices for more than a total of 20 years. After receiving her doctorate, she continued to be very busy. She continued her commitment to improving hospice care through research. She has written over 200 peer-reviewed articles and several book chapters related to end-of-life and hospice care. In addition, she continues to be a trailblazer, the first non-physician member of the board of directors for the American Academy of Hospice and Palliative Care. She's also an associate editor for the Journal of Pain and Symptom Management. Do you sleep? We're not sure. Dr. Parker Oliver has been the principal investigator for numerous studies. She is currently the principal investigator of 2 clinical trials testing interventions to improve the hospice caregiving experience, lower caregiver anxiety and depression, and improve patient outcomes. Her favorite job is faculty at the Barnes-Jewish College Goldfarb School of Nursing, another tremendous partner of the foundation. And they have just landed an important researcher who will be joining our team and leading transformation with Dr. Parker Oliver. Ultimately, Dr. Parker Oliver is elevating the conversation around the full spectrum of supportive care to improve the experience for more patients and families. Tonight, it's going to be a treat when Dr. Parker Oliver is going to discuss the transition of birthing and dying from home to institution and now to home-like environments. This evolution is just the beginning and will serve as a template for transformation of many more healthcare services. This is an exciting, forward-thinking concept, and like you, I am so excited and looking forward to hearing more tonight from Dr. Parker Oliver. After Dr. Parker Oliver's presentation, you'll have an opportunity to ask her lots of questions, and then you'll hear from Dick Miles, board chair of the foundation. And now, please welcome Dr. Debra Parker Oliver.
Wow, what a beautiful place. For those of you who are virtual, you can't see it, but it's amazing as we're overlooking the city. Thank you for that kind introduction, and thank you for the opportunity. It's amazing to me that we have this many people here to talk about dying. Do you realize that that says a lot in and of itself, and that people would give up their evening and listen virtually, or heaven forbid, dig through and find it and listen to something recorded? That says a lot about how far we've come. The joy of having been involved in this for probably 40 years of my career now is that you see where you were and you see where you've come, and we've come indeed a long way. It's such an honor and privilege to give you some background and some context tonight so that we can initiate a discussion about what the future holds for our community. Sometimes we're surprised when we find that 2 ends of a continuum are so similar. I had a sociology professor, and he said, everybody talks about a continuum and they think of it as a straight line. In reality, it's like a horseshoe, in that the 2 ends are actually closer together than the middle is to either end. And that's what we're talking about tonight with birth and dying. If I can find the little flipper. The good news that I want to bring to you tonight is that we are very strong in our palliative care in this community. We have a lot to be proud of. We have outstanding staff. We have customer satisfaction that is leading the nation. But I also have some bad news, and that is that it's under attack and it's a threat. And we need to learn from what we've done in the past in order to manage what we need to do in the future. And that's going to be the most important part of the talk and the discussion that we have afterwards. These are actually some of the roughest days we've experienced in hospice care specifically since its inception over a half a century ago. The very structure of hospice, all the regulations and the payments around it are more threatened today than they've been since its inception. Our leaders cite major problems in staff burnout and staff shortages, or if we think they're bad in the hospital, they're in critical condition within the hospice agencies. Regulator oversight, policymakers who quite frankly don't understand dying still after all these years, all are threats to us. The national experts are indeed predicting that within 5 years, our hospice will look different. And they're actually calling for major change. As healthcare has changed so radically in the last 50 years, the ability of that benefit to meet the needs of the community are actually questionable. So never has this talk been more timely than today. We basically have three objectives for today, but nothing is more important than the discussion that will follow. And so I hope that I generate a whole lot of thinking on your part, and if it's silent afterwards, I will have failed. I'll warn you in advance. My goal is just to set the background and some context so that we can listen to one another's ideas and come together as a community to make some progress. You know, historically, everything that was important happened at home. In fact, was anybody here born at home? Ah. My father, who's 82, was born at home. My aunt, who is 4 at the time, delights in telling the story because she remembers it so clearly. And when that happened, you know, it was convenient, it was celebratory, it was comfortable. This happened, it was natural. The same happens with dying. And when people are born in home, you have friends and family that help. Just a bit more than 100 years ago, half of the births happened at home. It wasn't an unusual kind of thing, or it wasn't a fluke little thing that somebody had to fight to set up. But babies died. Mothers died. And so a social movement arose to take birthing out of the home and into a safer place. And doctors and professionally led events began to surround it. And similarly, death used to happen at home. In fact, it was very common. These are not uncommon photos where family would pose around a dead body. We think that sounds a little morbid right now, but it was the same as though a newborn baby had happened. Pictures like this happened all the time. Funerals were at home. And maybe people made their own coffins, or a friend made the coffin, or there was a coffin maker, but the funeral, the burial was at the family graveside. And then a movement took place to take dying out of the home and put it in an institution and put it in the hospital. And that failed miserably. That was the worst possible place for it. So in Europe, they led us out of that and led us into a special place to die called a hospice house or a hospice. And in America, we took that concept and we brought it here, and we did not replace that with an institution, but we decided there's a medium way to go, and that's home with help. And so hospice in America took on a little bit different role. I've been working in hospice care and in palliative care before I was even a mother. And when I was pregnant with my firstborn, I was constantly thinking about the comparison between birthing and dying. And there are many things that are the same. You know, ironically, it's not only a social event, but it's also a legal one, in that both have certificates and both have to be pronounced, so to speak. The prediction in both is very tricky, and we're going to talk a lot more about that in a minute. In both cases, there's like this waiting period that you get very nervous about, and you want to know when the event is going to happen. And it certainly remains, even to this day, a family event. One case is a celebration, the other case is more mournful. Both events are painful. You know, we come into this world, it's very dramatic. It's filled with lots of things that have to be managed, and when we leave the world, it's the same. Things that have to be taken care of. Oh, went wrong way. The bottom line is that at both ends of that spectrum, it was a social movement that created change when people were not happy. Advocacy was important, and advocacy was part of creating an alternative. We now have moved to where we have a demand not for an institution, not for a traditional home, but for something that is home-like. However, there are very, very important differences that we need to look at. The first is the ability to predict when it's going to happen. We've gotten really good at predicting when somebody's going to be born. We'll miss it within a couple of days. We are really, really bad at predicting when somebody's going to die. Hospice nurses are really pretty good. I've seen them do it within hours. And if you ever really want a good guess, that's who you should listen to. Physicians are terrible. Sorry. Doesn't matter the tools we create. Our family members, hospice people will tell you this, our family members, they're released out of the hospital. They've been assigned to go into hospice, and they've been told they have months to live. They're grappling with the fact they have months to live, and they don't make it into the door of their home. That's how bad we are at it. We haven't found the magic formula for that. The other big difference, another big difference, is payment. Do we expect families to birth babies? No. We not only expect doctors to birth babies, but we kind of require that in order to get payment in many instances. In dying, what we're finding is that physician services are often unreimbursed. We're being told things like, it's not skilled, they're only dying. That's not skilled care. That doesn't require the use of a physician. We got to think about that and let that boil within you. The third thing is the role of the family is very different. In birthing, families have the privilege to choose how they want to participate in the birth of their loved one. Do you want to be in the delivery room? Do you not want to be in the delivery room? But they're not expected to participate in that. The hospice benefit in America was built on the premise that everyone should die at home and be cared for by their family. And that is a beautiful thing. And when it happens, it is amazingly wonderful. But everybody doesn't have a home. And every home isn't equipped to take care of a dying person. And any hospice person can tell you this. I'll never forget, I went out as a hospice social worker to make a visit, and I knew from the directions that we were going to probably have some problems because the individual lived in a camper shell that was off of the back of a truck located in the middle of a field. This was August. No electricity, no water, no sewer, and no caregiver. He was alone. That was his home. Your home is your castle. Was that the best place for him to die? He didn't have another choice. The second part of the hospice benefit requires that you have a family member who is able and willing to take care of that person, a family member or a friend. And when that works, it's wonderful. I had the best honor of my life to take care of my husband. I had a PhD, I had exposure to the medical system, and I had medical contacts in hospice and palliative care all over the country, and it was the hardest thing I've ever done. What about an 80-year-old woman who doesn't have that? What about a 35-year-old man who's doing that for his wife while raising 2 children and has no training to do that as well? There's willing and there's able, and not everybody has that. Those assumptions are problematic. The other thing is that we have maternity leave when someone is giving birth. And now we've even expanded that to where the males get to have maternity leave. And it's wonderful. They get to be at home and bond with the baby. Family leave, something that's new and wonderful as well. but it's much more complicated than that. It happens before the event that you cannot predict. And so as hospice folks, when we're going in there, the caregiver's trying to decide, I work full-time. When's the right time? When are they going to die so that I know when I can take my leave? And what if it doesn't happen along that timeline? And is it paid or is it not paid? And that varies dramatically as well. We're undertaking a new study, thanks to a generous gift from Foundation, that allows us to interview family members and hospice staff and learn about the final days of life and what that dying experience is all about. One of our hospice nurses said it really well. Policymakers need to understand how incredibly much support families need. This is hard work in the home setting. They're trying to live their lives, grieve a loss, take care of somebody who is often totally dependent, doing tasks for which they have little or no training, and manage all of that while trying to survive financially as well. A family member also said it very well. You know, we had to give 3 syringes full of medication. That's an unbelievable amount of liquid to put into the mouth or under the tongue of someone who's unable to swallow their own secretions. It took 2 of us, my daughter, to calmly hold his head straight and calmly talk to him, explaining what we are doing, and me to slowly squeeze the medication and make sure that it stayed in his mouth long enough to be absorbed. If that is not skilled care, then I don't know what is. If that is only dying, and we expect everyone to be able to do that, we need to talk about what people's perceptions are. So how do we make change? There are really 3 things important to policymakers. Data, research, voila. Second is money, right? We've got to save money. We're always trying to save money. And third is public passion, advocacy. It's 1,000 emails and 1,000 letters and news stories that hit the front page. And while research is a part of that, and it's very important, it's also important that you understand how research works, because research is not measured by its impact on policy. It's actually measured by how much prestige is brought to a university through publications and conferences and money. That has nothing to do with policy. And who are we talking to when I've got 200 papers. Who am I talking to? I'm talking to other researchers when I publish that. I'm not talking to the community. I'm not talking to policymakers. I bet they've probably never read any of it. But to be a successful faculty member, that's what you need to do. That's how your success as an individual faculty member is determined. So within our team, we need to realize that at the same time we have to do all of that, we also have to reach out and talk to a community about what the needs are, and to talk to the community about how we involve policymakers in making change. You know, we have done this before. We have changed healthcare practice before, both in birthing and in dying. We generated data that showed that fewer moms and babies died when you had that in the hospital setting. We had to show cost savings in order to get the hospice Medicare benefit to begin with. Cost a whole lot less in the home than it does in an ICU. No question about that. And people had to become passionate and demand change before change really happened. Let me share with you another really great example of a local effort that helped push a national policy. And it just so happens to be a fairly personal one as well. The Alzheimer's Association in 2010 created a ride across America with a series of relay teams who would ride their bicycles and gather petition signatures to increase funding for Alzheimer's research across the country. And this went all the way across the whole country. My husband from the University of Missouri and a Wash U team of researchers gathered together, and they rode their bike 70 miles along as one of those relay teams. I think if my memory serves me right, there were 4 or 5 of them. Never had met before, but they were all passionate about trying to change Alzheimer's disease. Incidentally, 6 months after that ride, my husband was diagnosed with stage 4 cancer. And so being in the best shape of your life does not prevent bad things from happening to good people. They delivered those signatures to Congress, great big book of them, rode their bikes right up to the Capitol steps, all walked in together. It was really, really powerful. And you know what happened? We have so much money going into Alzheimer's research now, and it is making such a big difference. In fact, my team has $5 million of that, and we've just put in an application for another $12.5 million to make a difference. That happened through community relationships and community advocacy for the process. So what does research have to do with this? And what does our lab have to do with it? We are called to improve the practice of hospice and palliative care, to look at the cost of care for dying, to look at the experience of dying and how to improve that, and look at the experience of caring for the dying to try to change that. And to do that, we got to pay for it. It's not cheap. You can ask all the people at Washington University. The premier research funding comes from the National Institutes of Health, which, by the way, are divided up by disease. And of course, death has no respect for disease. So you can see our very first problem is that we don't fit nicely into a little category of heart disease, Alzheimer's disease, cancer. We cover the whole gamut. So it's always an interesting experience, and that's one reason why I've been funded by 3 institutes, because our needs cross those institutes. But the obtaining of those federal funds is very important to a university. It gives the university its rank, it gives the university its prestige, and indeed, Washington University is one of the finest in the country, and our Department of Medicine ranks 3rd, which is really something to be proud of. This funding also, however, besides the prestige that it adds, comes with some problems. First, it is very slow. It will take, from the time I put in an application until the time I enroll my first participant, 2 years. Think about that. 2 years is a long time in healthcare. And many things change over that time, especially true in the hospice world, where we've got programs closing and opening and merging and all kinds of things. It's full of restrictions and costs that really have nothing to do with the research. That's the federal government, right? And it dictates what we can study and how we study it, because they establish national priorities when they decide to do that. It also has caps on things that haven't been changed in 30 or 40 years, despite inflation. But despite its challenges, that federal funding is what changes healthcare practice. And it creates the evidence in order to make things better. So we need that. The federal support addresses the data part and some of the money part. What you have taught me since I've been here is a very important lesson. It's the value and the importance of the private funding. It's the generosity of our donors that allows us to do actually the most important science to the people who live right here. Those funds are tied to what really matter to the people who give the money. They are readily available. We don't have to wait 2 years before we can solve a problem. And success can be measured differently. We can measure success by change and what happens. So again, our lab has to work inside the system and outside the system in order to be successful. We need the federal funding to change clinical practice. But we need the private funding to change policy and to meet the needs of the community. And above all other parts of the healthcare, dying is a community event. And we have learned we need to take care of our own. Let me share an example that you're very familiar with. Evelyn's house. This community realized the need for Evelyn's house. We saw that not everybody has a home, that not everybody has an able and willing caregiver to take care of them when they're dying. We recognize that families can't deliver babies. And many times they can't do everything that someone who's dying needs at home. So we didn't just sit around and talk about it, but created a mechanism to make it happen and created Evelyn's house. And it is working. Look at those comments. High family satisfaction, outstanding outcomes, successful in every way. But now the government says, maybe you don't need all those physicians all the time. Maybe all those people don't need to be in there because they're, I kid you not, just dying. Maybe that's not really a skilled thing. After all, we want people to die at home. There are no NIH grants that are going to solve this problem. There are no NIH grants to show the need for Evelyn's house, to create the state-of-the-art programs that happen there, that overcome the deficits within our healthcare system. This fight has to happen from this community. Legislatures, policymakers don't know what it's like to take care of somebody who's dying. We don't share those stories. I've been interviewed by newspaper people, and sometimes I'm torn, because in sharing that story, am I going to scare people? If they know how really hard it is that going to discourage them? I don't know. There are very few options, and no options in a lot of communities. So we have to ask the question, and that's what we're doing thanks to some private foundation gifts. What is it like to care for somebody who's dying at home? What is it really like? What are the skilled services that are needed? What is it like for the hospice nurses and the hospice and palliative care physicians? What skilled things do they do? Why are some families successful and other families not successful in making this happen? Why do we expect families to care for dying persons in home with limited resources when we don't expect them to deliver a baby, which is actually a much more natural process? What's our challenge? Our challenge is to lead a new social movement. It's time to build the evidence and to look at a new hospice benefit. And I never thought I would hear myself saying those words. I'm still kind of astounded as a person who grew up from the very beginning of that time. People are predicting it's going to be gone in 5 years. Are we just going to let it go away without being advocates about how it will be better and how we shape that? What does the new hospice benefit look like? How can we most effectively help patients and family? Let's keep them at the center of the discussion, because quickly it can turn to how much does it cost and can we afford it? And that discussion needs to be determined by you. You need to remind people that the patient and the family are the center, if ever they should be the center of something. How do we convince a healthcare system that is reimbursed and paid for treatment and cure that dying matters and that these people need help? I've outlined some questions here to try to get our discussion started in case we need it. Thank you for your time and your interest to come and talk about such a crazy thing. Your leadership has proven that we can do anything, and let's have discussions and become a leader in this rather than a passive observer. I have no confidence in anybody else can do it except us. So with that, I'm going to open it up for questions.
Thank you, Dr. Parker Oliver.
Thank you. And I'll try to repeat the question so everybody can hear. This question's about the work shortage, which is a crisis in hospice care, and it really is. You know, I remember when I started, nurses would leave the hospital and come to hospice because it was a great, rewarding place to be. And it is. I mean, you are so appreciated, and there's nothing like being able to do real nursing in the home of somebody who needs you. The problem is that that is also very demanding. And it's a 24-hour-a-day job, so that means there's call. And that means that you may be 50 miles away from where you need to be while somebody's actively dying. And we're so bad at predicting, we don't know how to shift those resources. And again, the reimbursement has not kept up. Payment has gotten better for nurses, but it's still got a long way to go. And you're right, if you think we're short in the hospital, it is an absolute crisis. I spoke with a hospice across the state just last week who they deliver outstanding care, but the most they can give families right now is a visit a week from the nursing staff. And the state came in and said that's not enough. And it isn't. But what are you going to do about it if you don't have anybody? So then you start putting people on a waiting list. Waiting to list for a dying person doesn't work. What is the capacity of a hospital? We faced this in COVID as hospices grew so dramatically overnight, and we just burned and fried our staff and our nurses. And it's not just them, it's social workers and it's aides. And that's part of what we've got to figure out. And we've got to figure it out in a way that people want to work there again, that it's a mission. It's as much a mission as it is about the money. And when you burn everybody out. Now, there is some research going on, and I'm happy to say that we're working with Goldfarb School of Nursing, actually, in a pilot project. We've got, again, private funding to do, to try to create some online support and some curriculum to help staff learn how to do self-care. Way back when I started, we would have regular meetings, support meetings for our staff. And we would talk about what happened, and we would talk about how horrible it was to sit all night and rock a dying baby. Everybody could relate about that. You could process that. We had time. We don't have time to do that anymore. And so it goes unprocessed, and that weighs on you. So we've got to teach staff how to take care of themselves and how to take care of one another. Here again is a place where research can come in and be helpful. I don't have the answers, but you're absolutely dead right about the problem. It is a major problem. How do we become better educated to help? You know, and that's a patient education, family education is an important part of what hospice does. It's an important part of the research that I'm working on. It's critical because we aren't just magically born with knowledge on how to help someone die, just like you're not magically born with knowledge about how to raise kids, right? And trial and error is kind of how we go, or we look at what has happened before, but if you've never experienced death before, you don't know. And it's further complicated by all of the emotion that you're experiencing. So you've got to process the emotion and learn how to do things. And you're doing things that aren't really all that comfortable on maybe your father or your mother or your spouse, very personal kinds of things. And we need a system that gives us time to do that education. If you're getting one nursing visit a week, you're not getting that education. It doesn't just magically happen. So again, here's where some behavioral intervention research can come in. One of the things we've created are some videos that talk about that and that talk about when to how do you know when to take someone to the emergency room when you're home by yourself? That was one of my major issues, and I have some training. Is it time? What are they going to do? Does it make sense right now? We've got to teach people. We can't just expect. Willing and able. And you've got to be able, and that requires training, because we're expecting family members to do things that doctors and nurses train years to do without help. So again, absolute. That needs to be a critical part of any benefit. Oh, virtual question. Oh, that's fun.
Thank you. Nikki asked a question. What can we do to help support your current research to create change for hospice? Are there options in addition to donations?
You know, advocacy is what, and it doesn't cost you anything. And it's a little intimidating to write a note to a legislature or to a policymaker. It's a little intimidating to talk about dying when nobody else is. But we need to bring this out into the public. Instead, what gets published are things that were in the recent New Yorker about all of the abuses and the horrible things that some hospices are doing, right? And so what does that make policymakers want to do? Well, cut the money, right? They're doing wrong, and so there's abuse. This much abuse, this much good, but we're going to focus on this and not all of this. And that's a problem. So letting people know it's important. Volunteering at hospices. Never have hospices needed volunteers more. No matter what your skill is. They have many, many different ways that you can volunteer. And yes, donations are important. Volunteer for research. People are scared by that word. Our research is actually pretty simple in comparison. We're not asking people to give parts of their brain. We're asking people to give their hearts and to try some things to take care of themselves. And so helping us connect with people so that they can participate in research is important. None of that costs any money. But don't underestimate the need for that extra funding. That's why I can interview people to find out what that experience is so that I can share those stories with policymakers. I'm determined to teach them what it's like to take care of somebody who's dying. And if I could grab them and put them in a car and take them out, I would. The question was around cost for hospice and comparisons. I have not personally done that research, but that research has been done. And it's been done on a national level, and hospice saves billions of dollars. Billions of dollars. And that's in the last final days, because what happens, the alternative is often the ICU, or the emergency room, the two most expensive places in a hospital, instead of home, or even instead of Evelyn's house. There is an in-between. We save a lot more money at Evelyn's house than we do when somebody's in the ICU. And that money is being saved not only to the insurance companies, but it's been saved to the hospital as well. And we're fortunate that our hospital is really beginning to realize that, and many are not. It's hard to measure cost savings, and that's a special area of research and one that needs a lot more work. And whatever new design we come up with, that's going to be an important component. But I think it's got to be middle. Thinking that we can deliver care for $100 a day, that's what hospices basically get, to take care of the dying person at home, and that includes everything. Thinking we can do it for $100 a day, when the alternative is several $1,000s a day, there is a middle ground. You can pay a little bit more on this end and still save all of this, but we have to think differently. And instead, if you are just a person that looks at the bottom line and they go, man, Evelyn's house cost us all this money because we didn't get any payment. We're not looking about all those people they would have been over here. You got to think smarter. Make a really good point in that advocacy is bigger than letters. It's also about education and change of a culture and normalizing death. And believe you me, I've been at it for 40 years. And the hospice movement's been at it for 40 years. And still to this day, when someone says, what do you do? And I say, hospice, and ask any of the hospice people here, they go, what? Isn't that depressing? And when families are presented all of their options for treatment, hospice is not often on the list, even after all of these years. But we can't stop. And we got to keep telling the stories. And it's one of the reasons why I'm gathering stories, so that we can share them, because stories are powerful, powerful change. And you hope somewhere deep inside, but it's once that person experiences it personally, there's nothing that will change you more than the loss of someone that you love. And especially if you are there by the bedside, and it's a good or even if it's a bad experience. But the hospital culture is not the place for the dying. That's not when you go in there, that's not what your goal is. That's not what you want. It may not be the right place for you, and that's where we need to have discussions before people go. But it's not the right place. We've learned that lesson.
Thank you, everyone. If we can take just one more question, then we'll do closing. Don't
I got to
worry, you can-
choose, but
you
I'm
can
around.
talk
I'm
to Debbie
around.
after.
I'm going to pick Dr. Codner because how can I not? His name is with mine, right? Thank you. You make a really great point, though. It's education not only of the community but also of professionals, and we've made great strides in that area with a fellowship program and with certification in all of the disciplines. But we got to keep the heart in it. And we've got to instill the mission, because it's the mission that keeps people going. It's the mission and the passion that these people are important, even if they're at the end of the hall. And that dying is not a bad word. The D word is not bad. It is going to happen to all of us. So thank you so much for your attention, and I look forward to follow-up discussion.
Well, that is food for thought. We put these leading edge discussions on 4 times a year. We try to get everybody to come to them. They are very compelling, but that one for me was something else. This is a need that is so great in our community, and it is a community need, and it is a community shortcoming, but it's a shortcoming in just about every community that I'm aware of. And I'm lucky. My parents both used hospice, and it was a great thing. And we're doing some great things here. And I think the happiest I've seen Patrick White in my life is when Debra Parker Oliver agreed to come here, because he was brought here to put together the supportive and palliative care effort, and he's got partners in that now. She brought a great staff, 200 peer review articles. I mean, think about that. And it is indeed impressive. I'm Dick Miles. I'm the board chair for the Foundation for Barnes Jewish Hospital. And life's journey, as you can tell from Dr. Parker Oliver, is a very complex journey. And it's really been enlightening to hear your insight and listen to you live and listen to your research firsthand and what you're finding. It's also comforting to know that Dr. Parker's expertise, knowledge, and dedication are leading the way to better lives and better life experiences for patients and families everywhere. So please consider sharing what you've learned tonight with your friends and family. You can also share the video of this program. I hope you will, because I think this is information that we need to get out to other people to get them thinking and get them supporting what is really can make a big difference in our community. You can also share the video, which will be posted to the Foundation's YouTube channel, Facebook, Instagram, and website soon. So thank you all for joining us. We are very thankful for your partnership now and always. And for those in person, feel free to stay, have a drink, have some food, and maybe have a chat with Dr. Parker Oliver. So thank you very much for coming. Stay well.